I'm very happy to be invited here by Elaine, who I met at I think a conference on diagnostic errors late last year. This is my home city, so I'm very happy to come back to Edinburgh. This is where I was born and raised and educated. So it's always a pleasure to come home again to Edinburgh. I'd like to start with the story of Emmaus, a small story, and I'm going to be working this presentation in conjunction with Dave over there because it has some videos in it, and because of the setup here I can't easily start and stop the videos, so we're going to be bouncing back and forth a little bit, but hopefully the technology won't let us down. So I'll start by going to the next one. I want to talk about a story with a local flavour. Who's heard of James Lind before? Anybody here? Okay, so a few. James Lind was a doctor from Edinburgh. In fact, he worked on board ships in the Royal Navy in the middle of the 18th century, when, of course, there was a lot of trade going on, a lot of empire building, and so a lot of sailing and navigation. And, of course, one of the big issues in those days was the absence of fresh fruit and vegetables on board the ships. The diet was very poor, and therefore there was high incidence of scurvy. And James Lind decided to try and investigate it because it was thought that perhaps there were some dietary supplements that might work in terms of preventing or curing scurvy. So he tried 6 different supplements on a cohort of initially 12 sailors that he selected as all being more or less at the same level of discomfort with scurvy. And these included things like garlic, seawater, doesn't sound like much of a supplement, cider, and citrus fruits. And what he found was that there was no effect for most of these supplements, but for cider there was some effect. And for citrus fruits there was a big effect. He noticed that you could actually measure a rapid improvement in conditions when people were given citrus fruits. He wrote this up in a paper which was published in journals in 1753, and then he did 2 further revisions in 63 and 71. But his findings were never accepted, really, until, sadly, after he died in 1794. And there was another Scot, in fact, also educated here at the Medical School of Edinburgh University, Sir Gilbert Blane, who actually was able to advocate the use of citrus juice by the Admiralty as a preventative measure for scurvy. And from the next year onwards, we saw dramatic falls in the incidence of the disease in the Navy. Why did it take 50 years for something that was, researched and written about to take hold in common practice? Why was it such a long delay? Let's move forward to today, where we are now, because it's really about how knowledge gets used. And in the case I've just given of James Lind, he created a knowledge base. He was one of the very earliest promoters of what we now think of as evidence-based medicine. And what's happened, of course, is we've seen a tremendous acceleration in the generation of medical knowledge and knowledge about patients. And if you look at this trajectory here, from the bottom left-hand side to the top right, we're on a kind of a journey up this very steep, increasingly steep slope. The x-axis is about access to clinical knowledge. So, what do we know about medicine? What do we know about how it works? How do we compare the effectiveness of different interventions? And there are thousands and thousands of papers being published every week to increase the body of medical knowledge. And if you take the y-axis, which is access to patient information, what do we know about particular patients and about the medications they're on, the diagnostic tests we've run on them? And as we've gone up this curve, we've moved from a position where we knew very little about either of these things, where medicine was more of an art than a science, to the point now where it's becoming much more scientific and much less, if you like, variable, much less random. And we've moved through this kind of journey from clinician consensus, a number of doctors agree that this is the best thing to do, to evidence-based medicine, which is based on trying interventions on big populations and getting statistically significant results back, to protocol-based, where we're moving into based on best practice, and now into personalized medicine, which is based on people like me. In other words, the groups of people that we're able to cluster together in order to compare them and decide what's best for that individual are getting smaller and smaller. And this is all based on information flowing around the system the high availability of up-to-date clinical knowledge and medical knowledge, and the availability at the point of care of information about that particular patient. And if you look at what this means in terms of, my area of specialization, which is health informatics and e-health, as we tend to call it in Europe, information needs to become even more liquid. So if you look at this kind of schematic of where care is provided, you can see that, on the kind of lighter grey box on the left, this is what I think of as the kind of healthcare, medical healthcare domain, where this is where the GPs are, where community care is provided, where we have acute, secondary and tertiary care. And this is quite well provided for these days in terms of systems to capture health information and digitize it. I guess you're all familiar with electronic patient record systems in the hospitals where you work. GPs are almost completely digitized now with electronic systems. But it's still not very, very joined up, and I think we have to keep on working at this whole question of how do you join up all of these different venues of care so we can create a single view of the patient. In addition to that, along the top bar there, you've got the Scottish Government, and in fact every government in Europe now creating national e-health infrastructure. They've got programs running to basically create a kind of a layer which would allow you to share information even more broadly right across the country, and in some cases beyond the borders of the country. And on the right-hand side, we've got this area where we spend most of our time, if we're fortunate, the area of home, office, in the car, out and about in the street. And there's a lot of health information being created here too, often by the patients themselves recording their own care and their own experiences. And I think the exciting thing about this world, the world of e-health, is that as we start to join these things up, we'll get better and better knowledge about what works, and we'll get better and better access to information about individual patients so we can make a better decision about their care. I'm not going to dwell long on this, but just to say that we see this whole journey towards better and better use of healthcare information as being kind of a gradient. On the bottom layer, we've got this, the basic IT systems that you're familiar with, on top of which we have patient information capture. And this is where we mostly are today. It's just about catching the information as we go through the care processes. As we get more sophisticated, we start to share the information within an institution. We view and exchange it within a kind of customizable interface, like a healthcare clinical portal, for example. We then go into the next layer, which is about moving information around between venues. And then if you get to the top two layers, the darker layers, we're into very interesting areas that I really want to focus on today, which are, can we start to use this fantastic body of knowledge to derive value and intelligence to improve care quality and outcomes, reduce variation, and basically provide a way of giving the best possible care at the most effective price. And at the top, we're then into this kind of nirvana position of having enough digital information to drive clinical decision making, clinical decision support. I'm going to show you a couple of examples of what I mean by that. So this is a journey. Every country, including Scotland, is on this journey of integrating its healthcare systems and the informatics within it. And it will take us still many years to get to this point, but I think we're all on the right trajectory. I want to start by talking about a project we're involved in. This is the University of Pittsburgh Medical Center in the United States, where we're part of a venture to create what's called the Center for Connected Medicine. And this is really about trying to really explore the outer edges of what can we do with today's technology. How can we start to use technology in a much more creative way to improve what happens in the ward, in the hospital? We're working on this with other partners like Alcatel-Lucent, Cerner, and DB Motion. Google are involved in it, strangely. Johnson Controls, Polycom for the video conferencing. And we've developed a solution that we've now spun off into another company. And it's called SmartRoom. And rather than talk about SmartRoom, I'm going to show you what SmartRoom looks like. And I'm going to have the CEO of SmartRoom, David Schauber, in a short video just explain what this concept is and how it works. So, Dave, can you roll the video? Thank you.
The Smart Room was created by healthcare professionals working to solve the kinds of problems that they deal with every day on the front line. It's an environment where the information is constantly changing, the patient's clinical condition is changing, new orders are being written, orders are being discontinued, and the activities around what's happening on a nursing unit can best be described as chaotic. So the concept behind the Smart Room is to deliver the right information to the right caregiver at the right time at the patient's bedside, where getting the information correct matters most. In the room, there are two screens. One is for the patient and their family. The other screen is a touch screen that's for the caregiver. Those screens have a different purpose. The patient screen is where the patient can access emails that are sent from home. We've developed a photo album, which is a really nice feature that patients love. Games, puzzles, the kinds of things you would want to do to entertain a patient while they're in a hospital, as well as present and provide clinical information such as patient education about tests that they may be having, patient education about their clinical condition, their disease state, and things that are really important to actually take advantage of and capture while that patient is lying in that bed. We took great care in designing a system where the user interface was very simple. A person can walk up and virtually figure it out simply by standing in front of the screen and following the instructions. And so within 15 minutes, a nurse or nursing assistant would be well versed in all of the features and benefits of Smart Room. One of the real values of the Smart Room that lives outside of the specific room, the patient room, is the improving the handoff of information between caregivers. So using the Smart Board as well as some of the other tools that are developed for Smart Room allow that exchange of information to happen much easier for the patient, for the care team. Our business partners are UPMC and IBM. UPMC is designing and building solutions to healthcare problems. We're very close to those problems. We're working at this from the clinician's perspective and the caregiver's perspective. IBM brings this global technology perspective, which adds tremendous strength to the overall offering. This powerful combination is creating a unique transformational product that is changing the way healthcare is delivered in hospitals today.
So that's Smart Room. Would you like one of those? You can see it's the combination of using the touch screens at the patient's bedside to capture what's going on as it's happening. Plus, what you didn't see there is the intelligence built behind the system, which will remind people if patients are overdue for particular tests or procedures or just to be turned or whatever. And this basically keeps the whole picture of what's happening in a ward completely up to date and visible to everybody on the board. So I think we can expect to see a lot more of this kind of thing happening. We're not the only company that's doing this. There's another very interesting small company from Denmark called Cetrea, who are doing something very similar but for the emergency room, the A&E department. So I think there's certainly a lot of potential in terms of using touch technology, more ambient capture of data, and just trying to keep it up to date in real time than we've seen so far. But let's now talk about analytics, because once you get healthcare information into a digital format, you can start to do some remarkable things with it. And analytics is really the next generation of computing. This is what we believe as a company. We've been buying many other organizations and bringing them into the company that have what we want, which is analytical technologies and applications. And use of analytics allows you to do several things. It allows you to reveal patterns in the data that you've got and provide insight, and I'll show you some examples of that. Allows